Good morning, Dr. Gardner. Good morning from Alaska. Can you hear me?
Yes, we hear you fine, Rabbi Greenberg.
Perfect. Great. Thank you. Rabbi Lazarov, our moderator, good morning. Welcome.
Hello.
Or good afternoon. I'm sorry. Welcome to the Zoom. We will wait another few minutes to make sure everyone who would like to get in will get in, and then we'll get started. Within a minute or two, we'll get started. All right, Bruchim Aboim, and welcome to this COVID-19 panel, a very special service that was provided by the Shluchim office to all Shluchim in response to requests from many Shluchim. We all know that we are now in a very special period, which was not what we didn't have in the world, maybe around 100 years. And obviously there is a huge confusion among Shluchim on what to do and how to do. And therefore, we are providing this panel with our medical experts in order to help Shluchim and Shluchos to be more informed, to be able to make really informative and responsible decisions. We all know the Rebbe spoke many times. We all know the Rebbe spoke many times regarding security in Israel. And the Rebbe always used to say that just like when it comes to medical issues, according to halacha, the only decision makers in the medical issues are doctors, professional doctors, mumchim in refuah, and only they have the say. The same thing when it comes to security of Israel, the only people who could give the say is professionals who are professionals in security and in Yanei Tzava. And therefore, we are very happy to provide this panel because all of us, Shluchim, we all have to make decisions based on medical information. In follow-up of this medical, panel, we are happy to let you know that we will have a rabbinical panel on Sunday at 8:30 p.m. this coming Sunday with Arav Yehoram Ullman, the Pesach from the Besdin in Sydney, who is a professional, who is a mumche in Inyanim, in Halacha Inyanim, in these issues, in many issues. Among them, in these issues, he wrote a beautiful and amazing psak that just came out from the Besdin of Sydney, together with the Rabbonim in Sydney, with real answers and explanations, the reasoning, how to do, what to do, when to open, how to open, and so on and on. So we were going to have, in addition, in a follow-up of this medical panel, we will have a rabbinical panel that we're going to have next Sunday at 8:30 p.m. So now I would like to introduce our experts, Doctors Morey and Tessa Gardner. Doctors Gardner are great friends of ours for many years. Two of their children live in Alaska, Eva and Dan, and the children, Lev and Abe, and also their son, Ari Gardner. Their children go in their footsteps with one change. The parents are brilliant doctors and the children are brilliant lawyers. Dr. Gardner's, both of them are infectious disease experts who dedicated their whole life to study this field, are great friends of Chabad. They know for many years the Shliach Rabbi Lando in St. Louis, great friends of Rabbi Morey Gardner in Victoria, where they have a summer house, and many other Shluchim where their children have been involved with for many years. We want to thank them, both of them, both doctors, Morey and Tessa. I want to thank you both for dedicating so many hours for all the Shluchim and especially in such a period. Personally, I want to thank them. We have been myself and my wife, we have been working with Dr. Gardner for a few days or weeks already on a mitigation plan for our own preschool, for how to reopen, when to reopen, and so on, and the details. And we are still working on it. It's not ready, but we'll be happy to share it as soon as it's ready with all the Shluchim. I also want to introduce our moderator for today's panel, our Shliach Rabbi Chaim Lazarov from Houston, Texas. Rabbi Lazarov, as we all know, is the son of the Shliach Roshi of Texas and one of the original Bada Shluchim of the Shluchim of Rabbi Shimon Lazarov. And Rabbi Chaim Lazarov is a rising star among Shluchim with his leadership skills and his dedication to the work of Shlichus, and we're very happy to have him as a moderator. So I think the plan is that Dr. Gardner will do a presentation for 10, 15 minutes or 20 minutes, and then they'll respond to questions. First, they'll respond to the questions they already received for the last few days from many, many Shluchim around the world. And then Rabbi Lazarov will be the moderator of the new questions and answers, which will be coming up on chat, on email, and some people would like to ask face-to-face. So I would like to give now the floor to our wonderful doctors. Thank you.
Gardner, we didn't hear you. Start again.
We cannot hear you because you have to unmute yourself.
Thank you very much for your kind words.
Yes, indeed. And thank you for the introduction. It's our honor and it's our pleasure to be able to speak with so many about such an important topic. We have a formidable task in less than an hour to provide useful information. We'll get right to it. If we go a little quickly, I apologize for that. We'll try to hit the right spot. But our real priority is to answer the specific questions that we're receiving, that we've received already and that we're going to be receiving, I suspect. And the general guidance documents that are provided by the government and that are provided by organizations such as Aguda and OU are in fact wonderful documents, but they actually don't answer the specific questions. So we'll get right to that. Let me see here how I can get to my screen share. And there, we're at the beginning. I should also mention that Tessa and I have been intensely involved with COVID since late January, and we're right in the middle of making the types of decisions that all the Shluchim out there are making. We're working closely with our Rebbeim here and with directors of schools and daycare and shuls and our own shul. So I understand the challenge that all this represents. There's some general truths that I just wanted to go over for an instant. And viral behavior is predictable. Viral behavior cannot be changed. Human behavior is unpredictable. Only human behavior can be changed. And hoping for the best, it's a fine thing to do, but it doesn't make for good policy. I thought I should speak with a mixed messaging, which is so unique with this health emergency. We didn't see it, we've never seen it in the past. We didn't see it with SARS, we didn't see it with MERS, we didn't see it with Ebola. But there are different messages coming down from the highest levels, and I know that's producing confusion. We will be giving our view how to get through that. I wanted to mention that what we pay the most attention to are the agencies and the individuals and the organizations that follow along and match our priorities. Our priority is health. Pikuach Nefesh is a major driver in all of these policies. The one thing we don't want to do is make someone ill. We don't want to place someone at risk of losing their life. Our religious organizations, Chabad, OU, Aguda, and others prioritize health. Our health authorities prioritize health. But in most of the country, with a couple of exceptions, one of them being California, they're not really in charge. And for the first time at a national level, the CDC is not fully in charge. The government is prioritizing the economy, which is important for the country and for all of us, but we are going with those organizations that are prioritizing health. Now, our unique closeness and the rush to phase one, with the majority of states not fulfilling the basic criteria of having a downward slope in either new infections, if they're doing enough testing to be able to tell, or at the least hospitalizations, it's being rushed. And for that reason, given the very unique closeness of our community, which makes for increased risk.
The Orthodox community.
The Orthodox
meaning the Orthodox community.
Right.
Where there's such a close contact with so many people on a normal basis.
Right. So we're recommending, and this is generalized, certainly true here in our city, it's true in our state, it's true over most of the country, that we are recommending waiting 2 weeks beyond for each step of opening, beyond what the general community is doing. We certainly cannot do anything less than health departments or governments ask us to do, but we can go more slowly, we can do more to protect our community. I just wanted to point out, this is something that everyone actually needs to become familiar with. You can see the cursor here. This is St. Louis. Our cases started going down on May 3rd. They're planning on reopening on May 18th, which is 15 days after. So they're fulfilling those criteria. We're not doing enough testing, but our hospitals are not full. Our ventilators are available, and this hopefully is the case wherever you are. If that isn't the case, it requires more caution, and the at least 2 week buffer will provide an opportunity for us to see if the curve starts going up before we place ourselves at unnecessary risk. I wanted to go through very quickly what the phased reopening means. It's basically monitoring the number of infections, monitoring the number of hospitalizations and the number of deaths as we go through opening and come out of our homes. Phase 1 lifts the shelter-in-place restrictions. Schools remain closed. There are limited business openings. Groups are restricted to 10 or less. It's mandated to continue social distancing, hygiene, disinfection, adding temperature and symptom checks. Masks are recommended. They should be required from an infectious disease perspective, given what we know about this infection. We think, and I'll speak to that, I think, a little bit later also. The travel restrictions are maintained, and I know that's difficult for our community, for our observant community. It's difficult with another Yontif coming up, but we do believe it's very important. But exceptions to restrictions, we're now in a period when, in fact, we should be making those as opposed to absolute blanket restrictions. So I would suggest that you consult with a rabbi. They can consult with physicians, and we can provide specific
what we have found in St. Louis is that the Rabbanim are still holding off on anyone traveling. But as individual cases come up and people and their congregants ask them, then they refer them, to one of the infectious disease people usually, to see if it can be worked out in a safe way.
And in the meantime, we're monitoring. And again, we're opening up in 2 to 3 weeks. All the shuls will be open together. 1 or 2 may be a little slower than others, and that they're having to spend more time getting ready. If and when infections go down, new infections, hospitalizations go down, hospitals are not being overwhelmed for 14 days, then we go on to phase 2. Some states are already going on to phase 2. Again, from strictly speaking, according to the guidelines that were released a month ago, too quickly. In phase 2, you leave your house except for the most vulnerable. You left your house in phase 1. You continue to leave your house in phase 2, except the most vulnerable. Schools and daycare camps, according to our governmental agencies, may open. Whether we do open is a separate issue, and we'll speak to that a little later. More businesses will be opening, though telework is still recommended. Groups are increased to 50, but said to avoid crowds. People should try to avoid crowds. Maintain all social distancing, hygiene, disinfection expectations. Use masks, continue temperature and symptom checks at businesses and venues. But travel, and here there's a disparity. The CDC indicated travel shouldn't be eased in phase 2. There was a decision made at a higher level to ease and resume, in particular, business travel. And then, of course, continue to monitor for infection. If it continues to go down for 14 days, for 14 consecutive days, which can be over a 2-week period, or maybe it'll take a month before it goes down again. But whenever it goes down without going up in phase 3, if it goes up, then we have to go back to earlier phases and more restrictions. Phase 3, the vulnerable leave their homes very carefully. Schools are back to whatever the new normal is. Businesses open, including bars, which have been a focus of cluster infections. In the past, maintain all social distancing, hygiene, and disinfection. As we go through these phases, one's compulsiveness in adhering to basic social distancing and hygiene actually becomes more important. Use masks when in crowded environments in mass transit. You certainly have the option of using masks in general. Temperature and symptom checks should go on. There are no travel restrictions. Visits to nursing homes are allowed. And we continue to monitor infection rates, ready to drop back. A new normal will exist, and we'll be defining that new normal by our behaviors and with what happens over the next few months. Until we have a vaccine available, or people talk about herd immunity, which requires that 60 to 80% of people have been infected and survived. And we don't know enough about this virus to know whether that will be effective or not. We don't know enough to know that a vaccine will definitely be possible, but we are optimistic, and I don't know where that came from, but it seems to be getting worse, and I'm not sure why. I hope we're not being...
Oh, do you think we got Zoomed?
I think we got Zoomed, yes. Went away, good. So, again, the new normal, I believe, will include masks until we have either vaccines or herd immunity or drugs. Drugs would have to be oral drugs. They could be taken prophylactically.
Those, by the way, were our grandchildren in Alaska and San Francisco and Cleveland, all wearing their masks.
It looks like this may be a battle of the white hats against the blue hats, but the guidance for our unique, very social, very close-knit community has been provided, as I said, in documents. But at this point, what we'd really like to do is go on as quickly as possible to answering specific questions. Looking at the time right now, I see we're at 1:50. I'm going to take a couple of minutes, actually, at this point.
Maybe the organizers can try to do that.
Well, I'm sure they're doing their best.
Yeah.
So I thought I should mention, why did this particular virus become a pandemic? And it really has everything to do with the fact that it's respiratory spread, and because asymptomatic carriers,
is it clear?
No. And asymptomatic carriers are spreading the majority, which means you can't tell that someone is potentially infectious. Though we do believe that the most infectious individuals are clearly the ones that are ill. This just demonstrates that they're very tiny droplets that can get into your lung when people are singing or screaming or shouting or crying. But in most cases, the majority of the droplets that are produced will land on surfaces, and that's where they become a problem. If your hand touches it and you touch your eyes, nose, or mouth, you become infected. But the fact that it spreads by respiratory, that these are coming out of a respiratory tract, covering surfaces, and are available to be inhaled, is the reason that we have a pandemic. A simple 2-layer mask, I want everyone to know, can reduce the droplets that are produced by 99%. Huge numbers of droplets, 1% is still a lot, but a dramatic reduction, which is why every single study, every indication, though we don't have long-term experience yet, suggests that masks are of enormous value. Everyone wearing a standard simple mask, every simulation, every specialist in the area of mask use and pandemics believe that if everyone wore a mask, everyone, then the epidemic spread would stop. The epidemic would come to an end. There would be fewer than, each infected person would infect fewer than one individual, and when that happens, the epidemic is over.
Should we try to
No, that's not necessary. I've made most of the important points. What I'd like to do now, without using the PowerPoints at all, the limited number that we had, is to go on to answer the questions in groups. We're delighted to receive the number of questions that we've received, and apparently there are twice as many now. But with regard to transmission, there are questions regarding, is social distancing only to avoid being too close to someone who's sneezing or coughing? And what I want to emphasize is that talking loudly can produce droplets that go about 3 feet. Yelling or screaming, also 3 or 4 feet. And sneezing and coughing sends those droplets out to generally 9 to 20 feet. More than the usual 6 feet or 8 feet that we talk about in terms of social distancing. So you certainly want to avoid people who are coughing. If those individuals are wearing a mask, it reduces the distance dramatically. Yeah, it goes, it's not just sneezing and coughing, it's someone who's perfectly well, asymptomatic, is going to remain well, is infected, and when they speak loudly or they sing, they infect someone. There was one choir, 60 people, one person was asymptomatically infected, documented over 32, actually over 50 people became ill and 2 died. Singing in the absence of illness can clearly spread it. Same thing has happened in airplanes during SARS, and we believe the mode of transmission is the same with this coronavirus. Does the use of Sidurim and Humashim need to be restricted each week? Each person uses only one book. Actually, I think the context of that question was originally that they only have davening in that particular community, a small community on Shabbos. And then, of course, in most cases, when you're talking about minyanim during the week, people are using them all the time. What we're recommending right now is that everyone have their own siddur, that everyone have their own chumash. And if not, then all of those need to be cleaned. They should be cleaned in between use. If you pick up a siddur chumash, again, the virus doesn't go through your skin. Your hands will be potentially contaminated in case someone using it was ill, and just by coughing, davening, spread it onto the siddur. It needs to be. It can be transmitted if you bring your fingers to your eyes or nose.
I think one of the things that this question asked, it was from Shmuel, is that if his services are only once a week, does he have to do anything? And the answer is no, because it survives on paper and cardboard for 24 hours. So if you're going to only have services once a week, that you really actually don't need to do anything to your shul or your building. You should do your normal janitorial cleaning after several days, so that if there is any contamination, that the janitorial staff isn't exposed. But as far as the COVID and books and everything like that, you don't have to do anything if you're just doing it once a week.
Right. 1 week is very safe. In the studies that have been done to date, there are a limited number, but they were done well. Glass is up to 5 days. Newspapers and cardboard is 24 hours. Wood is 4 days. Plastic is at least 3 days. Stainless steel is 3 days. Copper's a little less. There'll be more information on that, but that gives you a sense. When it comes to backyard and driveway minyanim, Yaakov and Mendy asked, would there be any risk if one shaliach lives in a town where you can have unadvertised minyanim in the backyard? The standard view of backyard minyanim is that the level of monitoring and enforcement of social distancing breaks down in a backyard environment, as opposed to a structured, carefully simulated, tried out, trialed shul environment. So the official, were given the fact that human beings are unpredictable, as I said before, even when they mean well, is to avoid backyard minyanim. Now, if that's the shul, if the backyard is the shul, and if someone takes responsibility for actually trying it, and if in fact the jurisdiction that you're in, the state, the city, allows at least 10 individuals, if they allow more than that, the number needs to be limited. But again, it needs to be structured and monitored, is the current view, and not loose. There are questions from Mendy from New Jersey. Says, New Jersey's been hit harder. The governor did open up the beaches and drive-in religious services, I think focus more at Christian denominations. Can we do parking lot mincha marivs with proper guidelines? And again, if it's opened and you can do it, and you choose to move ahead in concert with the state as opposed to waiting a couple of weeks to see how things go, again, it needs to be structured. One has to think about a number of things. it's not just enough to put chairs and space them out. You need to have a place for people, maybe another chair next to it or a small table. And if they stay there, they all have to be cleaned. If people bring their own, then less so. And that's where the parking lot comes in, where people can literally drive up, take out a chair or a small table or 2 chairs. The cars are all spaced. It have to be designated spaces, so everyone's ideally, at least 10 feet apart.
Can we show the film?
Sure.
Yes.
Yes.
Okay, let's do this.
Yeah. Oh, I don't have it up on mine.
I got it.
Excellent. There's a photograph of sharing in that way.
Here we are in the Shul parking lot. 5 cars on this side. Everybody brings their own chair, so we're not disinfecting. We have 5 cars on this side. Everybody took their chair out of their trunk. 10 people. And we have 1 Hazan in the middle over here. We have our security directing the cars. And we could have 10 people here. 10 people, 10 cars in the other one. That's 2 minyanim. In that parking lot, 2 minyanim, that's 4. In the parking lot of the center, 2 minyanim is 6. In the parking lot where the Hasala trucks are, 2 minyanim, 8 minyanim. 80 people at 6 a.m., 80 people at 7 a.m., 80 people at 8 a.m., and 80 people at 9 a.m. We could have 320 people to pray at Memorial Day when it becomes legal for 10 people to congregate outdoors, and we could have a beautiful minyan. Thank you very much for this.
Is that acceptable? Doctor, tell us.
We are not praying here. We are.
So is that acceptable or not?
It's for the number of people that he had there and the way it was structured right there, what we were seeing, and they were doing a simulation, which is the right way to do it. I think I would be comfortable with that. When you get to 320 people, human beings are unpredictable. There's no way to monitor 320 people. Also, Rabbi Lazaroff shared that he subscribes to that, but in fact goes a step further, again, limited, monitored, and that is puts people not sitting at the back of their car, but sitting on the driver's side. So everybody sits on the driver's side, so there's a barrier, there's an additional barrier. But again, a lot of factors involved. Maybe people want to see one another directly, and that way they won't be tempted to see them in another context too closely. But that's just to give you some sense of the type of structure that's necessary, the type of planning that's necessary, so as not to have a problem with
I think the risk there is that with such a large number of people at this early stage of the opening up, if 1 or 2 or 10 people are infected, even if they're wearing a mask, they're probably not wearing an N95 mask. And these look like many elderly people. So I think the larger, the huger your group, the more you do put people at risk. Whereas if you can contain it to a smaller number, I think it's far better.
You want to touch briefly on how droplets are spread?
Yeah, do you have a video?
I'm happy to show a video.
Yes,
please.
If you would show that now, then we can speak to it. This is a regular standard sneeze. That's going about 9 feet. A very vigorous one can go up to 20 feet. These are 2 gentlemen in South Korea. The South Koreans have been working on this. Here you may not be able to see exactly what's going on, but here they are about 4 feet apart.
Here's the other, and they're talking.
They're talking, and those tiny droplets, they're being called micro droplets. They're aerosols, really. You can see going between them, even though they're about 4 feet apart. And when you're infected, each one contains infectious virus in large numbers.
Here's someone who coughed.
This is inside a room, a standard room, an auditorium, a classroom. That one individual coughed, and these are the minutes going by. And these are aerosols, the micro droplets.
Seconds, I think. And
this is how large numbers of people get infected at weddings, how they get infected at choir practice, bar mitzvahs, bat mitzvahs, and in shul when people are singing and dancing. This is at 20 minutes, and they're there. It's high density. We don't know exactly how many you have to breathe, but they're there in the billions and billions. We don't know whether the infectious dose for a human being is 50 of those, or whether 100 or 1,000, but certainly not more than that. How are they, what happens is when you sneeze, a lot of the secretions in your nose, or when you cough, come out in big globs. The bigger they are, the faster they fall. And they fall on surfaces, or they fall on the floor, a foot and a half, 2 feet, 3 feet. The smaller they are, the farther they go. But when, in fact, a small number of those when you're just talking, but a much larger number when you're speaking loudly, like I'm doing now, or when you're shouting, or if you're singing, your vocal cords are vibrating very, very, very quickly. And if there are any secretions, you generate a pretty substantial aerosol. Sneeze and coughs the most. That was a sneeze. And that was a simulation based on gas and fluid dynamics that people have been working on at MIT and other universities. It turns out all of our past restrictions that so many physicians are used to, that's why there's some pushback here, were based on data that was first generated in the 1800s and most recently in 1933. We've now updated that, and we have a much more sobering view of,
in 2020.
Of aerosols.
These are updated in 2020.
Yeah, this is all done in the last 6 months.
They're asking if you have a certain mask that you suggest, and how would it be outside? Is it the same?
Well, there are different kinds of masks. You'll hear these ratings. You hear about an N95. That means that mask is going to get about 90, it's going to protect you from about 95% of the particles the size of the COVID virus. And if you have just a plain flat paper surgical mask, that's going to protect you somewhat less than that. A fabric mask is a little bit less than that. And no mask is obviously no mask. But go ahead.
I have some specific numbers that we've been generating recently. The simulations that have been done suggest that the fabric masks and the 3-layer paper surgical masks, which have become affordable and are available now, will, as I said, reduce 99% of the material that you would spew out otherwise. But if they're just 60% effective, then if everyone is wearing them, there is no transmission. If everyone wore, emphasize it again, fabric mask or surgical level mask, everybody wore them. And the way that works is my mask protects you, your mask protects me. They're not very good at filtering. If you have an aerosol out there and you're breathing in, the holes in the mask, the electrostatic properties of the mask material are not adequate to prevent the aerosols from going in, which is why in hospital settings and where we know large numbers of aerosols are being produced in procedures, we use N95s. In talking about N95 though, you see N95s that have those little plastic blow-off valves, and there are also a lot of regular masks being marketed because it's easier to breathe. When you exhale, it just goes right out. That doesn't protect the other person. There are a couple of states that have outlawed them. If you have a valved N95, you need to wear a surgical mask over it.
Or a cloth mask.
Yeah, but they're very effective. They're very effective.
It's basically because it's preventing the liquid stuff that you would spew out if you're coughing or sneezing or spitting. But the little tiny microscopic things can still leak out.
But a lot of them will be caught in any case. Moving on to preschools, which Tessa's been working very closely with preschools, and it is very challenging.
This is a very appropriate slide. We've been discussing this. I've been discussing this with Rabbi Greenberg too, and then with Rabbi Lazaroff. But we have recognized for a while that beards prevent a mask from being safe. So because it's basically like having a ventilation around your mask. The air just goes right through the beard, and it's not a viral filter. So it's really important to try to have a large enough mask that really fully fits around your nose. It needs to have a piece of metal on every mask that fits around the nose. And the beard mask that's perfect. Yes, it should go way beyond the beard, and the whole beard should be inside it, so that that makes it a much better, safer mask.
The seal is important.
Yeah.
And so when you have a homemade mask, you want it to fit as snugly as possible so that it doesn't have large gaps, because when you exhale, it'll go out through that. And when you inhale, you'll be sucking in most of your air through that.
Now, the other thing is you'll see on the news and everything, people have their masks down below their nose. That's useless. Okay. So if you're going to wear your mask, make sure it fits up over your nose, and don't pull it down to talk, and just don't keep it down there because it's more comfortable. That it needs to cover your nose and mouth. Okay, now we got a lot of questions about preschools, schools, and camps. And that's what I've been working with Esty so much on recently in the Alaska Chabad. And so what I thought I would do is just mention the different people that asked these questions so that you'll know I did read them all. So Hannah asked a question, and Simcha and Nosson and Shimon. And the questions were basically about, what do you do when your local region is telling you it's okay to open up and you're concerned about making your kids or your parents or your staff sick? And is that the right thing to do, or how concerned should you be? And what about pikuach nefesh, since that's really our goal? Okay, so in answer to that, first of all, you should definitely not be less stringent than your locality. If your locality is not open to the stage that says you can do a preschool or a camp, don't do it, wait. But what we're recommending is, because all of these governmental and local guidelines are meant to try to encourage opening up as soon as possible, and what we're recommending personally, and what we're hoping to do in our city and so forth, is you wait another 2 weeks beyond that, so that gives you time to see if the opening up of the secular part of the community has resulted in an increase in cases, so that you don't get injured by cases out there that you weren't expecting. And so you might even want to wait an extra week and go through some dry runs to sort of test how you're going to go about opening up your preschool, get everything in place to be able to properly, safely open up when the time comes that you decide to do that. Camps are another matter, and I'll address that in a little bit. But with the preschools, there are many questions. One set of questions relates to can children be safely gotten together if they can't touch each other, or if they're too young to wear masks. You can't wear a mask if you're under 2. You shouldn't. It could be dangerous. But 2 and up, it's recommended that they wear a cloth mask at least, with supervision, and that maybe they don't need to wear it for sleeping, for napping. So if the child is old enough to be able to wear a mask, then that's helpful. You can distance them out. You can have individual baskets or boxes for personalized supplies like crayons and scissors, things like that a child might have shared in the past, but you can individualize the items that they would need to use. They can use them in tandem. You can spread out the tables so that they can be apart, so the kids can be at 6 foot distance. You can teach them about hand washing. You can make it into a fun thing. Happy birthday twice, or Yom Haleda Sameach twice. That's about how long it takes to do 20 seconds. You can teach them not to be afraid of masks. You can make masks with funny faces on them. They can put masks on their toys. Their parents are wearing masks. It's really, kids are very flexible and very accepting. And as far as food and lunch, things like that, snacks, you have to really think through that. And the best thing is to have the food prepared outside of the classroom, say in the kitchen, and then have it brought down by a person who then, and the children are spread out. They each have disposable dinnerware and plasticware, glasses and things. It's going to be a little more tippy, but they can do it. And that somebody serves them, rather than having communal buffet or that. So you want to make sure that you're doing that. You want to make sure that nap time is safe. Some places use mats, some use rugs, some use sheets on mats. You can wash, many places have laundries where they can wash the sheets once a week. If it's a named sheet for the same child, you don't have to wash it every day, just wash it once a week. You can do staged drop off and pick up, so that you can have arrival questionnaires that the parents have agreed to fill out, saying their child doesn't have a fever, the child is not sick, no one at home has a fever, no one at home is sick, no one at home has been recently exposed to COVID, no one is at quarantine. So those are you can develop a series of questions that are going to all be answered no before the child can actually be brought to school. Then you can do things like having a touchless thermometer that a staff person can use at the door, at the entrance, to check the parent that's going to be bringing the child in, if the child has to be brought all the way into the classroom by the parent, or if they're comfortable leaving the child with the staff, you can do that. But you can have parents buy into that, and you can you have to get in place protections for your staff. So that is a matter of talking to the staff, seeing what they're comfortable with, what they know, what their level of interaction with the different age groups is. So how their interaction with an 18-month-old is going to be different than their interaction with a 4-year-old. On the other hand, the 4-year-old could get injured and cry and need to be hugged, and that's going to happen. So you need to be able to have appropriate protection, personal protection for your staff. And if everyone is wearing a mask, that would be the best thing. And what can be acquired is smocks or cloth gowns for the teachers to wear that can be washed. They can have 2 gowns per day. One can be changed at midday. Then at the end of the day, they can be thrown in the wash. You can have gloves when needed for things like diaper changing if you need to, but they still need to do hand washing. You can have face shields that are rather inexpensive if the staff is concerned about getting contaminated during crying with a diaper change or something like that, in addition to their mask that would protect their eyes. You can have nice, attractive glasses that are just clear for people that don't wear glasses. That's some eye protection.
Do you want to talk about bathrooms?
Wait, not yet. And so if you go through all the things that the preschool does with the children on a daily basis, it's napping, eating, playing. You have to talk about shared toys. Shared toys should be cleanable. So you have to go through what kind of toys do you want to have. If you're going to have stuffed animals, they should be one stuffed animal per child per day. Then that gets thrown in the washer or something, or put away for a number of days until it's recycled. You can think through those things. You have to have in place a cleaner that comes in to clean the preschool several times during the day. It used to be hourly. Thank God it's not hourly anymore. But you can do it several times a day, the commonly touched surfaces, the floors. You have to think about how you're going to be having playtime outside. You can take the groups, you can cohort the groups of kids and say, these 10 kids are going to stay with the same teachers, same 2 teachers maybe, same 10 kids, and they're going to go out and play together. And then the other group that's with another 10 kids with 2 teachers, they're going to go out at a different time, and in between, the playground railings and things like that can be wiped down or spritzed down with a sanitizer. So you just have to think about those kinds of things that the kids do. Then you need to think about the bathrooms, and so it's preferable.
Before we move into the bathrooms, thank you so much for all those great, amazing, very detailed examples. So as you're going through it, I want to make sure we cover a lot of other questions that are coming on along with it. So can you talk to the general, they say that studies that kids are not spreaders. Why are we considering daycare opening over regular school opening? And is there a difference? And which teachers are at risk? If a teacher is pregnant or a senior, do they need to be considered for replacement before they go into daycare?
Right.
And mainly about children that are not really ready to wear masks. Is it realistic to expect that children to wear masks?
You can't have a child under 2 wear a mask. It's not safe. And they also can't wear it when they're sleeping and napping. So there is a little bit of exposure there, but the teachers should be wearing masks. But I would say that it is risky for an over 65 teacher or someone with an immunocompromised state, cancer or something, where they are considered an asthmatic who's symptomatic, someone who's considered at risk. I think someone like that should probably consider they should not take care of the youngest children, and they might want to consider being relocated to an office setting or something, or doing lesson planning or something else where they don't have face-to-face with the young children.
How about pregnancies?
Pregnancy, so far, there have been a very small number of studies that have followed pregnant women, and most of those have come from Asia. And in those studies, the pregnant women did fine. On the other hand, there have been some newborns that have not done well and have died. And so I think that's something that we just don't know enough about yet. And I think with an abundance of caution, you could perhaps, as things go on, we will get, on a weekly basis, we get more and more information as more and more data comes in and it's published and it's available. So I think that those situations could be handled on an individual basis depending on the concern of the person. And if it's possible, I would say maybe no one pregnant should be there.
What age is a teacher too old to work in the daycare? Or
well, we say 65 is the at-risk older group.
About the Kawasaki new interest in this problem?
Right. Yeah. The Kawasaki. Now, here's the thing: children. Now we know we have a lot more data now about children. When this began in our country here in February, we hardly had any data on children, and people said, "Oh, there are 9 children that are reported from Asia that had it, and they all did fine." And so now we're finding, and now we're finding children do get it. They get it at a slightly less frequent rate than adults, but they do get it. But they also get similar symptoms if they get sick to adults by and large, but they have milder symptoms usually, and less often do they have symptoms. So there are more children who have it that are asymptomatic than there are adults who are asymptomatic. At least that's what the numbers so far show, and they may change. That's the thing about this disease. Now, up until just the end of April, we were not aware of this new disease, which is a Kawasaki-like disease that is extremely severe and hits older children. We used to see, as infectious disease doctors, I've seen many cases over many years of infantile and young children, toddler Kawasaki's. That would hit 1 and 2 and 3 and 4 years olds, but very rarely over that. And we knew what the treatment was. We knew how to diagnose it. We didn't know what caused it. Now we're seeing this same type of presentation of disease, just like Kawasaki's, but it happens in the middle-aged kids, and it happens up to age 19. So it's happening in 9 and 10 and 12 and 15-year-olds, which we never saw with the Kawasaki's. It was a rare child of 15 who actually had real Kawasaki's. We always doubted if it was really that. So now what we're finding is this. Let me just tell you what the disease is, and that there have been about 200 or so cases now between England, I think France, and New York. And we're now seeing increasing recognition of this in California. There in 30 or 40 states it's happened already. It's not very frequent. It's just a small percent of children who get it. But when it happens, it's very, very severe. And it's an inflammation of all the blood vessels in the body, which is what Kawasaki's is in infants. And that means it can give liver disease, brain disease, heart failure, kidney failure. It's rashes, red eyes, red tongue, high fevers, lung disease. It's a very bad disease. They are treating it now as they treated Kawasaki's, which is with gamma globulin, high dose intravenous. It seems to help, and they're treating it with very careful supportive care, and that seems to help.
So with all that said, should we be making a difference with regards to opening up daycare versus Hebrew schools, day camps for elementary school children, or not?
Well, I think that it's right now we're talking, the impetus for opening up the preschools is that this is something that is needed in the community because the parents have to be able to go to work. And I know that's been an economic impetus from the government, from the local regions, and also from the congregants in your Chabad houses, and the people that send their children to your places, your schools, your preschools. So I think opening up the regular older children's schools, kindergarten and up, I think should wait until the community and city-state guidelines open up their schools. So I think if you're in a region where your public schools are closed, I don't think you should open up your Hebrew schools for the 5 and up. But I think if you're...
So earlier you were saying that when the state or local institutions open up, we should wait 2 weeks before we consider opening. Are you applying that same principle to schools as well?
You know, your schools, the Jewish schools open on different, they have a variety of opening dates, you know, and the secular schools have a variety of opening dates, public, private, you know, whatever. So I think that would have to be assessed at the time that you get closer to school, and look and see what's happening in the community, keep track of the numbers and see how the rest of the opening up has gone. And then you know, I think you have more control in a way over your Jewish schools, your Orthodox day schools, than they have over the public schools. So I can't answer that. I don't know the answer to that, whether you should wait an additional 2 weeks, because that gets into what do you do for the school year? How do you end up, you know, how do you get your required days to have the kids finish their necessary days in school?
All right, let's move into other subjects. So somebody lives in a country that has 2,604,000 confirmed cases, 23 deaths, and the country's still in lockdown, or they are beginning to open. There's very few deaths, and it's been proven in that country that community spread is not serious, at least not reported serious. Can they take a more moderate approach, or do they also need to wait 2 weeks past what the locale had determined?
I think that if their locality is that good at having controlled the disease, I think they probably have a lot more leeway to open up, to go from one phase to another.
Yeah. If you're in a place like Singapore or South Korea, lots of testing, a high level of transparency, or in the United States, if you're in a very low density environment, Montana, Alaska, then you have a great deal more flexibility there.
What about states that have no cases, but because of political situations, they're still closing? Or do they need to consider before reopening? I mean,
There's a question there. Do they just have no cases really, or do they just have no testing? So it's hard to answer that question. I think Alaska is in a unique situation because they have available testing for whoever needs it, and they have a very small number of cases.
All right, let's go into practices for disinfecting. So what kind of methods would you say would be best to disinfect equipment with? Is it wipes? Is it Lysol? Is it, what would you consider would be an appropriate way to get disinfected?
Okay, well, yeah, okay, so you need to collect, ideally if you get a bunch of Clorox wipes, Clorox Lysol wipes, or some equal product, there's a government site where you can look up any product. All of the products that you use for cleaning have a little FDA number at the bottom on the front, and you can look up that number and they'll tell you whether it's okay for COVID. And if it's not okay for COVID, it's not, because they've tested it. So you want to, and it might be fine for cleaning and for bacteria and for toilets, but it's not going to get the COVID that might be in the toilets. So you want to check out your cleaning products. You need things that can sanitize surfaces. If it's too expensive to buy the Clorox wipes or you can't get them, you can make your own bleach solution. There are recipes for that online from the government also. And you can put paper towels or, gauze pads or something, large gauze pads in a canister, put it in the bleach solution, use gloves, use that to wipe things down. There are spray bottles of a sanitizing solution that you can use for some surfaces. You're going to need to have, those are the cleaning supplies. You're going to need things to clean the floors. You might want to just make your own bleach solution for mopping floors. You should have a HEPA filter vacuum if you're vacuuming rugs. If you're cleaning toilets, that's another thing. We should actually touch on that.
30 seconds.
Yeah.
You want me to speak about it?
Yeah, well, about cleaning toilets, if you can put lids on your toilets, that's much better because they aerosolize and we know that it's in stool. So that would be worth an expense to put lids on all your toilets.
Yeah, we've not demonstrated it's infectious, but we worry about it because there are high levels in the stool and it settles in the bathroom on surfaces.
And there was a question about opening up bathrooms. Okay, you can't restrict bathrooms if you're having a Chabad House or a shul. You can't keep people out of the bathrooms. So what we're going to be doing in our shul is we're going to have cleaning supplies in there, spray bottles, Clorox wipes. We're going to say, try to use the restroom at your house before you come, and try not to go until you go home. But if you have to, then clean up after yourself. Sterilize, sanitize the faucets, door handles, doorknobs, toilet flushes, spray the toilet seat. Make sure that you leave it clean for someone else, not just clean, but sanitary. And we're going to ask people to buy into that. Because you can't have somebody coming in and cleaning between every person.
But that is the only reasonable approach that we've run across. We only have a minute or two left, and I wanted, when it comes to summer camps, that's an even more complex situation than the daycares, because all of the activities require interacting very closely or using the ball or sitting in a canoe, all these things in a swimming pool. It's very difficult to know what to do with that. And it's very difficult to know what the infection curve is going to be like. So we've right now been recommending at least delaying the start of summer camps so that parents know in advance not to count on them. Now you can restructure summer camps to be a different type of activity. If kids just need to get together so they can
and learn, maybe they need to get together and learn outside, sit in chairs or something.
But playing on their own iPads together.
But what you could do, we want the Chabad to stay in touch with their families that rely on them. And so the thing to do is not to advertise the camp as a definite, but say, here's what we're thinking. We're following the guidelines, but we're also want to keep you safe and your children safe, especially in view of this Kawasaki-like disease, which hits camp-age kids harder.
Camps do go forward with opening, and they're bringing in counselors from New York, California, Florida. Do they need to bring in their counselors 2 weeks earlier to quarantine first for 2 weeks before they can open?
I think so, right.
Yes.
If you're coming from a hot spot, I think the counselors should come early in quarantine.
What if somebody's preschool is a handful? It's only 3 kids. Hebrew school is only 1 classroom of 1 family. Some of these very small Chabad houses with small daycares. Is there more leeway with regards to not being as concerned because perhaps they're just not exposing themselves to multiple families, or are we concerned about daycare regardless across the board?
I think there's less concern if it's a daycare for 1 family and with 1, that's just like a 2-person bubble, basically, a 2-family bubble. So that's of less concern. You still have to do all the safety things depending on the age of the caregiver, and you don't want to end up in either giving or catching something. So you still have to be very careful, but it's much less risky. And if it's a 2 or 3 family group, that's again less risky than a 25 family group.
Doctors, I know that we are generally out of time, but everyone's begging for more questions to be answered. Are you available for a couple more minutes?
We set aside the time.
We have as long as you want. We're fine.
Okay, wonderful. So let's keep going. I'm going to try to go down the list and let's get everything covered.
I have to ask something about the camps. Back to the camps. The camps are, as I said, the older children, and they're somewhere between daycare and school. So I think we just have to wait. And the important thing is to please keep your families close to you in terms of updating them.
Now, the CDC has reported that chlorine kills the virus, and therefore swimming would generally be non-concerned. There's been reports that really it takes 15 to 30 minutes to kill the virus in the chlorine. Is it a problem for there to be group swimming? Do we have to wait until the locale determines that public swimming pools can be open? And if it does open, do we have to wait 2 weeks?
I would do that.
It's relevant.
I would do that.
Yeah, it's been very frustrating because there's conflicting data coming from the CDC in a very unusual fashion. And it may have to do with the fact that their funding's been cut for a decade progressively, and they don't have enough people to check. But you're right. You have these where it says there's no issue with pools, there's no evidence, but this is only a 6-month-old disease. So the absence of evidence doesn't mean anything. In the same site, you can find that it takes 15 to 20 minutes, and the levels that they indicate are necessary even during that period of time is way beyond what you would find or could tolerate in the swimming pool. So we just don't know, actually.
And the swimming is not as essential as a mikveh. And I know this has been addressed by many Rabbanim and many infectious disease doctors in regards to how to keep the mikvehs open.
So if somebody has antibodies, they're immunocompromised, they're a senior, perhaps they have antibodies, maybe you want to hire staff and you'd like to see if they have antibodies. So people take antibodies at all into consideration with regards to who they hire or fire for their staff.
I think the problem is in some areas like New York, it's widely available. You can get a test. Probably in Alaska you can get a test, but not everywhere. And so so that's one problem. So one problem is it's whether it's available or not. Second problem is it an accurate test or not? Is the test itself accurate? are there false negatives or false positives? What we know with the antibody tests is they're usually about 20% false negatives. And if they're positive, they're probably valid, probably. But we also don't know if that antibody that is detected is protective. We also don't know how long it lasts. That's the
Let me give you a guideline. If in fact the positivity rate in your area for testing that goes on in general with any of the tests that are being done is less than 5%, then all the antibody tests have a false positive rate around 5%. So if you have, like New York, we have 20 to 25% of people who are infected, a positive antibody test may be a real positive. In low frequency states, it's more likely to be a false positive than a real positive.
But they're going to get better tests. The tests are going to get better. All the tests are going to get better. They're going to be more widely available. And so this is an area that we all can hope that's going to get better, and we can use it when it becomes reasonable to use it. And
somebody had the virus and they want to come back on staff, they want to come back to work. Do they need to, what steps do we need to take to ensure that we don't expose our community to the virus?
There are pretty clear guidelines that the government did come out with, the CDC came out with. You have to be without fever for 3 days. You have to be, 10 days after your beginning of your symptoms. And in some cases, you have to have 2 negative tests separated by a certain amount of days. So those are, we don't know if that's sufficient, but that's a start. And
I thought the World Health Organization said 14 days.
That's what I was going to say. We don't know. That's what our government is saying. And so we, as infectious disease doctors, we're not that comfortable with that recommendation. We would say if you wait at least 2 weeks, and if you have 2 negative tests separated by a couple of days, then that's good. But we have seen people with positive PCRs, to test the virus in their nose, for up to a month after they've gotten the disease.
But we've had some reassuring data recently where if they're cultured and also tested for PCR, the virus is not infectious.
Yeah.
But 14 days to us makes much more sense. The CDC, when it started until 3 weeks ago, it was 7 days.
So let's break down that timeline. We're saying somebody has the virus, 14 days on final symptoms, take a test that comes out negative, wait 72 hours, take a second test that comes out negative, then we know we can bring them back on staff?
That's the most, well, it's actually 14 days from the onset of symptoms and not having a fever for at least 3 days.
Right.
And then 2 consecutive tests.
So 14 days from when you lost your sense of smell or you had a fever, okay, or whatever you had. And then also that you should not have had a fever for the past 72 hours. And then if you add on top of that, the 2 negative tests, that should be quite safe. And also we do see that there are people that come and go with their symptoms. They relapse a little bit, and it may be because they're overexerting themselves, they're working too hard, they're not sleeping well, and we don't understand enough about this virus to know how long it takes to really have the body shake it.
We've seen that with other viruses
seen that when we
don't have treatment.
And we've seen that with people that we've followed, that they're getting better, then they go out jogging, for 2 miles, and then the next day they don't sleep very well, and then the next day they're relapsed.
There have been reports that the virus lasts longer on plastic over other surfaces.
Yes.
People, though, can have an easier time disinfecting plastic over cloth surfaces. Is it better to have upholstered chairs in your shul or plastic chairs in your shul?
Well, it survives about 24 hours on cloth, paper, cardboard. Okay, so if you have a fabric chair, you could rotate your chairs, just put them in a room, don't touch them for 24 hours, and they're good to go the next day, if you had enough chairs. Okay, you can't really clean them in any other way. You're not gonna dry clean them every time. So the other thing is plastic and metal. Some people have metal chairs or combinations of metal and plastic, the common shul chairs. Okay, those you either would have to put away for 3 days and have enough chairs to rotate, or you just wipe them down with a Clorox wipe, and that's probably the best option.
And if you don't have Clorox wipes, again, it's all over the internet.
Just make your
own Clorox solution
and just wipe it down, right?
But bleach is becoming available.
But the other thing is wood chairs. Some places have wood chairs. It survives on wood longer. It's 4 days. So wood, you would have to wipe it down.
So, and by the way, at the Aloha conference, there will be a discussion about this as well, about using it on Shabbos, these wipes, and how wet they have to be, and if they could be used or can't be used, and that will be discussed on
if
the.
Not wet, they don't work.
Yeah, they have to be wet.
And it has to give off its wetness to the surface that you're cleaning.
Yeah.
If you so it becomes a challenge for Shabbos.
Right.
So, and moving on, another subject, it's become very popular for Shluchim to share the taste of Shabbos with their communities? What precautions do they need to take if they want to make challah and chicken soup for their communities? If they wear a mask, a 3-ply mask, is that sufficient with mask and gloves and hand washing, preparing those production, or do they need to do something more?
I'm fine with that if they have a safe house. If they're wearing a mask and they're hand washing, they're washing their hands, they're putting on their gloves, and when they take off their gloves, they're washing their hands. They do the challah, they take it out of the oven, they put it somewhere where it's not going to get coughed or sneezed on, wrap it up. That's fine. I think that's fine. I'm okay with that. If they want to cook chicken for somebody and they want to, the best thing would be wrap it up in foil and then give it to the person that way. Let it cool, give it to the person that way. Tell the person, unwrap it, and then they should wash their hands before they actually take the food out from the inside. Then it's completely sterile, like you took it from a takeout restaurant.
Because of that, takeout restaurants. Some people have been very concerned about taking out the takeout restaurants, and they haven't been buying from takeout restaurants. Is that a concern that they should or should not buy from them? Should they wait for a certain time, or is it just?
I think they should know their restaurant. I think they should know their restaurant, and whether that restaurant is one that they know the people, they have confidence in the people and their precautions. I think if it's cooked, I would favor cooked food. If you're giving things to people for Shabbat, at least until we're sure that there's not an uptick I think you could give food to people now, but I think if in terms of giving people salads and uncooked cold things, I would probably wait on the uncooked cold things until at least a couple weeks go by and that things are going in the right direction.
One advantage of kosher food, at least wrapped before the delivery,
Right.
and when it comes into your home, just like anything else that comes in, you can wipe down the outside and then open it up. But it's a matter of having confidence in your restaurant.
And then you need to know how to unwrap something so that it's not, because if the outside got contaminated during the delivery process for some reason, then you want to make sure that what you take out of it is clean. So you want to open it, wash your hands, then take out the stuff that's inside.
Well, Memorial Day is coming. Can I have over a family for a barbecue outdoors in my backyard?
What city? You're in Houston.
Yeah.
You can do anything you want in Houston, right?
No, what do you think? I mean, would you recommend or not recommend having over a family for Shabbos?
Are you going to be bubbling? That Alaska is now bubbling. They had an order on Friday that you can bubble with one other.
Define that.
A bubble is you've been sheltering in place and doing all the right stuff and not contaminating yourself and you're healthy, and you have a friend or another family that's been doing exactly the same thing. You can make a bubble with that one family in Alaska now. But you have to agree, each family, that they're going to only bubble with you. They're not going to then go bubble with somebody else and then bring in a third party to maybe stir up the mixture there. So until the things are changed. So, I think that if you, say, had relatives and you were confident that all of your people in that, I would say probably 2 separate groups at the beginning, are perfectly observant of the masking and the sanitation and the, all of that, then you have to make your own decision for yourself on that. But if your locality makes it okay, that gives you, at least, you're not going against your locality, but whether you want to wait to see what happens or whether you trust that family completely, that's really up to you and your knowledge of each other, the 2 families.
The big difference between other types of interaction and interaction over food is that with the others, you can actually still wear a mask.
Right.
And again, the germ theory is real. And if you wear a mask and they wear a mask, right, and you observe good hand hygiene, that's another advantage of the mask. Covers the nose and the mouth, so you don't touch them.
Now, theoretically,
but when you eat, you can't do that.
But theoretically, you could have 2 tables separated by 10 feet. You could have separate food for that table, separate food for the other table. You could talk at a distance, not in each other's downwind.
But if you're inside and
you have to think about
generated,
those things, but I wouldn't do it indoors yet.
If the indoor issue with aerosols is of concern, there are things you can do. Aerosols are so light. I mean, the way they develop is it's such a minuscule drop of fluid that when it sits around in the air for just a few seconds, all the fluid evaporates and all you have left is the virus. Right. But they're so light that if you open 2 windows and there's unless it's absolutely still, it'll dissipate very, very quickly. It doesn't take much. Blowing it around with a fan isn't enough. It'll just stay in the environment.
The fan will just spread it to everyone in the room. But if you open a window and put on an exhaust fan or put a fan in the window sucking out, so that you get an opposite side of the house cross draft, that is actually a helpful thing.
In Houston, you'll have a higher electrical bill, but I think it's worth it.
Well, we are very used to high electrical bills. It's the most air-conditioned city in the world.
Yeah.
But those questions you have to answer. You have to keep an eye on what your community is doing and how much confidence you have in the people that you might be choosing to bubble with.
So when it comes to masking, is there a recommended method of when to discard or reuse a mask? Do you have a mask with you there? You would demonstrate the proper way of taking it off and putting it back on if you do reuse it or discard of it? Because that has been a very touchy subject and people don't have,
and actually, there are a number of places. It used to be very difficult to get N95s. Certainly, you can't get the medical grade ones, but you can get N95s from all sorts of other companies now.
Any difference between N95 and KN95?
Yeah, right.
Yeah.
You can. Yeah, you
Here.
can. This is a.
Now, here, I'll go through it. This is a standard med-surg mask that we ordered recently for some.
Called a 3-ply, right?
What's that?
It's a 3-ply?
It's a 3-ply spun polyester.
Yeah, pleated.
Pleated mask. So
Ear
it comes
loop.
down. And I'll show you and the proper way to put it on is with a fresh mask, you just grab it by the sides. You have to take your glasses off. Form it to your nose, put it over your ears,
And then reform it.
And then pull it down under your chin.
And reform it to your
and
nose.
then reform it to your nose again.
Because it has
and
to
you
have a
end
good
up,
fit.
Again, depending on your facial structure and the size of the mask, you can end up with a pretty good, and you can tell it's a good fit. When I inhale, it'll suck in.
And you don't even have to smile. Everyone thinks you're happy.
It doesn't balloon out. Now,
But then you don't want to touch it.
There's
In other words, once you put it on, you
Right.
don't consider
Now-
the outside contaminated.
Right, the outside's contaminated, and so when you take it off your ears and you pull it away. You try not to touch the outside of the mask, and if you're going to store it,
Not a plastic bag. Paper bag is better.
it
It lives longer on plastic.
Yeah, that's what I had there. But what you do
This is just to show people, to keep it clean.
A paper bag, like a lunch bag, you label one side as dirty. And that's the side that you put your mask, the front of the mask in. So that
Or you could put a nail on a wall somewhere and hang it up.
And hang
That
it up.
would be preferable. Then you
Yeah.
don't even have to touch it.
And-
Just have pegs in your house for everybody, separated by like a foot, not 6 feet. But just hang the masks up side by side, everybody with their own mask with their name on it. Label the mask before you put it on, because these are hard to come by, and we used to throw these away with a single use. And now
Disposables?
those are just, yes,
Yeah,
these used to be disposable. We would go through one with every patient, okay?
You wash them?
What?
You can't wash.
You can't, no, these
Now,
are paper.
let me tell you how these spun synthetic masks, 3-layer spun, the way they actually work, it's not that it's actually trapping, because the spaces microscopically are pretty big, but they develop as a result of what they are. It's just like the same reason that your socks will stick to your towels, in the dryer. Again, the virus is so small that the electrostatic charge in this is generated when it's manufactured, and it sits around and is stable, is such that the virus will, smaller particles than it should be filtering actually adhere. If you get it wet, so if you wear it long enough for it to get moist,
Then it's kaput.
it stops working.
Yeah. So what
it can dry
you can
out.
dry it out. So that's why what you need is about 3 masks per family member. You hang it up on a peg. You're going to need 3 pegs per family member, or clothespins on a line.
But you don't want to contaminate yourself with it.
You don't want to contaminate each of your 3 masks with the dirty one. You want to be able to rotate it, take the cleanest one to put on one day. After you wear that, put it on a peg or a clothespin, then take the next clean mask, and you'll rotate them every 3 days, and they'll dry out in that period of time. After about
one study that compared all surfaces and said that the mask actually lasted up to 7 days on its surface, more than any other surface.
But it's not on your inside.
Right.
On the outside.
That's why you have to be careful.
That's why you have to be very careful not to touch the outside. But you want the mask.
About carbon monoxide poisoning.
Yeah, But you want the mask to dry out. And you could probably use it for a week or 2 or 3, depending. If you crumple it, then it's kaput. But
now people who have lung disease and retain carbon dioxide, CO2 retention, should in fact not, they have to be very careful with masks because it can really be problematic.
But a regular healthy person can wear a KN95, N95 mask all day and not pass out?
Yes.
Yeah. Our healthcare workers are doing
even without a valve.
We've done it.
Even
now,
without a valve.
These are valve, and the reason I have these is because these were industrial masks and not really ideal for hospital use. And I would always use it when I was mowing the grass. I always had a lot of these around. You put it, again, the bottom one needs to go over your neck. You want to keep the front away. This has been used before. And you put it around your neck. Then you grab it in the front. You put it under your chin. You pull it up over your ears, and you form it to your end. Now this fit is dramatically
this has a very
better
good fit.
than the other. And this is very protective. But you see there's a valve here. So if
we need tried and proven tricks for glasses wearing people like me. How do you get it not to fog up?
Tight fit.
Take something and put it, the anti-fog ski stuff. You can get it at REI or something.
Yeah,
put anti-fog stuff on your glasses.
Or
soap. Just take a tiny bit of soap, a drop of soap and some water, put it on your glasses.
But let me approach it a different way. If it's fogging up, then it's not a good fit.
Yeah, then you're leaking. If it's fogging up, you're leaking.
If it has a valve, it doesn't protect anyone else. This is not protecting Tessa.
Right.
So then you put one of these simple surgical masks over it, over the valve, and now it's fulfilled.
Now he's very well protected,
it's ultra protected,
and I'm very well protected.
She's protected.
Right. But then the taking off is important.
What I found helpful for my glasses is that I use air savers. There's these little devices you can get for masks that goes around the back of your neck instead of around your ears. Because my ears fall off and my beard pulls the mask out, my ears at the end of the wearing of it feels like it's about to fall off.
Yeah.
Taking it off, again, it's the harder part. You break it down, just reverse, pull it up, keep it away and avoid the front of the mask.
And then wash your hands after you put your mask on because you might have touched it.
All right, you mind going back to camps for a moment, if you don't mind? Yes? Camps. Is there any difference to make between day camps and overnight camps? There's an argument to be made that overnight camps is a bunch of young people quarantining with each other. I mean, if they don't have any staff over 40, 50 years old on campus, is there any concern with an overnight camp operating, even if day camps are being told not to operate because they are all staying on campus, sleeping overnight together for a month?
The ideal way, obviously, I mean, it becomes very complex because the risk of transmission is greater. Everybody's bunking together, if there's an infected individual, everyone will be infected. If one could structure it, I've thought about this a bit, that you're very careful using masks, doing distancing for the first 2 weeks, basically quarantining everyone when they arrive. And then if everyone remains well, then your only risk, and also even if they're asymptomatically infected, they will not be infectious by the end of the 14 days. And then you can, it's business as usual.
No, but where are they going to sleep? They're going to be going back to, you're saying they're going to go be
to
their homes, to their parents,
if they're going
the first
for
2
2
weeks.
months,
So then they're going to be getting.
No, we're talking about overnight. I'm talking about an overnight.
No, but he's talking about, but you're saying you're going to quarantine them.
No, I'm saying in the camp, they would simply, they would do physical distancing for the first 2 weeks.
But if they're sleeping in bunk beds together, there's not physical distancing there.
Well, it would just expose the 3 other people in the bunk.
That's a really hard question.
But you see, when you're dealing with a respiratory virus like this, it's problematic. And the problems occur in groups. So if it's a small group, again, small cohorts, the risk is less. If it's a bunkhouse with 16 or 20 kids, the risks go up. And as the risks go up, one has to become an infectious disease specialist, becomes less enthusiastic about.
I mean, in the event that we end up with a lot of testing, that could help you be more confident in having overnight camps. But we do know from 100 years of infectious disease, that any kind of dormitory situation, whether it's a prison, a university, anything, a camp, anything where there's overnight where there's nursing homes, where there's collections of people sleeping in the same place 24 hours a day. They have outbreaks of everything, and anything that gets there spreads through the thing. That goes for meningitis, it goes through strep, it goes for COVID, it goes for influenza. So anytime you have constant close contact in that setting with many people, you are at risk to have even, you could have somebody get a strep and everybody's going to get a fever, then you're going to freak out. So that would be hard.
Yeah, there's one thing that I wanted to sort of emphasize again with regard to safety and being safe. And my last PowerPoint had it. You think I might be able to show it and get away with it? Let's see.
I'm not sure. There seems to be somebody on here who wants to have some fun, but let's see. Hopefully. Although if somebody starts messing it up, we'll have to turn it off, unfortunately.
Yes, yeah, I understand. There we go. What I want to talk about for a moment is that, we actually have in the hospital setting learned what's necessary to stay safe. I mean, when all this started, there were a lot of healthcare workers who were becoming infected. And the fact that we hadn't seen that before speaks most prominently to how different this virus is than influenza and other things. If there's anyone out there who still doubts that this is unique and much more dangerous. But what we've come away with is that if you follow all the steps compulsively, which requires a real culture change, and that's what I'd like to see happen. All IDs would like to see, and that's what we've done in our own. I did infection prevention and control. I was in charge at a major hospital for 38 years. And things only got better when the culture actually changed. So what that comes down to with this disease is really adhering to the social distancing of 6 to 8 feet, washing hands frequently, and there's some really nice old data that recruits in dormitory settings and with respiratory illnesses, the more they wash their hands, the fewer infections they develop. So the hand to face, part is very important. It's a simple thing to do. You should be washing at least 10 times. Anytime you interact with anyone, you touch anything that isn't yours, you wash your hands or use hand sanitizer. When I was in the hospital, I would do it 30, 40, 50 times a day. Didn't have any skin breakdown. It worked.
The other good thing about wearing a mask is it keeps you from touching your nose and mouth.
Right.
Now, it doesn't keep you from touching your eyes, but if you have glasses on, then that takes care of that. So that's your T-zone, eyes, nose, and mouth.
This is very hard for adults to do. Never touch your face. When we videotape a 2-year-old class in preschool and videotape a medical grand rounds at the finest university in the country, the number of times that an individual touches their face or their nose when we've done this in the past was exactly the same in this preschool class in a medical grand rounds. So adults, we touch our faces all the time. We touch our noses, our mouths, our eyes, rub our eyes, and you just have to not do that. High touch surfaces should be disinfected frequently, a few times. I mean, in your home, outside doorknob, inside doorknob, in shuls, in daycares, there should be the ideal, if you have a busy and a large daycare, you need one person who maybe can help with the cooking, but will spend the rest of the day cleaning continuously. So disinfecting is important. In the hospital, it's critically important. Wearing masks, I hope I've already made the argument for that. Wearing masks is of real value with this type of disease process when there are asymptomatic or pre-symptomatics. Pre-symptomatic is someone who's asymptomatic, but 3 days later they're ill, who are spreading it. And the masks are really terribly important.
If we could
and checking for symptoms in a shul or in a daycare, in hospitals, it was such a surprise. When we started asking people with this disease, we started asking them if they were ill. It seemed sort of silly to us initially, but it turned out that there's such a strong tendency, it's sort of programmed into all of us, and I think with dedicated individuals like you have in your settings also, that you work ill. And when you actually answer a questionnaire, it becomes shameful to show up when you say, yes, I have a sore throat. You really can't show up. So that monitoring and checking temperatures in one large system they picked up 15,000 people over the course of the last 4 months, a huge system, 15,000 healthcare workers, and half of them did in fact have COVID-19.
Wow. So, okay, Dr. Gardner, we want to end while it's amazing. This was a great session. I have one personal question
one travel question for someone.
Yes.
I feel that the person that asked, there was one travel question from Mendy.
Oh, there was a travel question. A shliach got stuck in a different state and wants to go home.
They got stuck in another state and they want to go home. It is possible to do it, but driving is much safer because you can take your cleaning supplies with you, even if you have to stay in a motel. You can clean the motel room before you sleep there. You can take your own food. You don't have to, all you have to do is get gas. So it is safer. But flying, if they can only if they're so far away and they can only get home by flying, they need to consult with an infectious disease doctor to be told exactly how is the best way to do it. I have done it with people.
We've been hearing some disturbing stories about what's going on in planes now, because now that they're cutting down the flights, they're getting crowded and people are not wearing masks. So
and the bathrooms are not safe in the airplanes.
Yeah. So it is.
But we have one more personal question of a shliach here. Someone with low asthma and Down syndrome, are they considered immunocompromised?
Exactly. So I saw that was the other one I was going to say we didn't address. It depends. The Down syndrome depends on what else they have. Sometimes they might have other associated things like cardiac disease, in which case
low asthma in this case.
Okay, asthma. Okay. Well, anyone with asthma would be considered a bit of a high risk, depending on how severe their asthma is. And so they wouldn't be considered high risk just because of their Downs, but more because of the underlying other diseases that they have. And
two different children.
Diabetes as well, correct?
Diabetes as well, right, yes.
Okay, thank you so much, Dr. Gardner. I'll let Rabbi Greenberg wrap this up. I want to just close with one thought for everyone here. Before you rush to open and get so excited, now I know exactly what I need to do. You need to take into consideration to do it cautiously, because chas v'sholem, when they start doing contact tracing and it all traces back to Chabad of your town, that where 5-10 people contracted the disease and somebody died, on your conscience, and as well as the Chilul Hashem, you want to be certain to do it cautiously and follow a guideline. Any guidelines, it was better than no guidelines. Please follow a guideline to ensure that even if it does trace back to your Chabad house, you did everything you could. Because of course we need to have the Eibishter's help to be sure we get through this time, and we hope you'll join us as well for the Halacha session. I'll let Rabbi Greenberg finish it up. Thank you, Rabbi. Thank you, Dr. Gardner.
Thank you for
moderating. So I just want to say thank you to Dr. Gardner for dedicating their time for us. And just to add what Rabbi Lazarov just said, we would be happy to share Rabbi Ullman's guidelines, as well as other guidelines from other organizations, from rabbinic organizations, the OU and a few others, who have done an amazing job in providing guidance especially to synagogues. We will be happy to share as soon as we complete our mitigation plan for preschools with Dr. Gardner. We're happy to share with all the Shluchim. It will be on the website, the Shluchim will provide it. So people, like Rabbi Lazarov said, if you do open, and when you open, you must have all the guidelines in place in a most strict way. I could tell you from my personal experience with Balabatim who are not listening to the rules. Even when you tell them in the face that they have to have, I had a class with 2 Balabatim, very choshev Balabatim. I sent them an email and I said, I'll have a class if we all sit 12 feet away, not 6 feet, 12 feet away from each other. We will wear masks. We will have food next to each other if we eat. We'll say l'chaim next to our little table, but nobody will get close. They came into the class, they put the mask on for 1 minute, they took it off. So we have a problem with our Balabatim who are not listening to us. Some of them will think it's a joke, and some of them will think that we are paranoid, and some of them will think because so many Lubavitchers have passed away, and we have so many relatives, so we are overreacting, and so on and on. So we definitely, the biggest problem will be is to educate our Balabatim and to insist that we have a rule, the rules are, and if there is someone by the door, stands there and gives a mask before you walk into the Chabad house, and if you don't put a mask, you cannot walk in. This will be a real issue, how to train our people to listen to the rules. So therefore, I would suggest you send out an email with the guidelines, and you say, this is the guidelines from our rabbis, and there's no other way around. So this is very important, and we're going, as Rabbi said, we're going to have on Sunday, going to a halachic session with Rabbi Ullman and he'll give us or provide more answers, halachic answers on the subject. So again, Dr. Gardner, thank you so much for all your time and for spending time with us personally and working on the mitigation plan. And we hope that very soon that with Hashem's help, we will be out of this whole darkened period that we are facing with the coming of Mashiach soon in our own times. Thank you. Thank you, everyone. Thank you, Rabbi Lazarov.
Thank you. Thank you, Dr. Gardner.
You're quite welcome. Our pleasure.
Our pleasure, really.
I'm sure there's going to be a recording of this presentation, and I'm sure the Shluchos will make it available. Everyone should be able to if people couldn't be here at the beginning, would like to hear it again, I'm sure there will be a recording of this presentation. Thank you. I want to thank the Shluchim office and Rabbi Gedali and Basi Shem Tov for making this available. Thank you, everyone.
We'll send you a couple of other references also. Some of the things we alluded to were maybe difficult to find, like the full text of the CDC guidelines, which has some specific language for schools.
Thank you. Thank you, everyone.